Hello, everyone. Welcome. We're going to wait just a few more minutes to give people time to join us. Okay, hi, everyone. We can get started. So Randy is, I think she just left her clinic, and so I think she's rushing home to join the meeting. So I'm going to get things going. And then our student, Catherine Wang, she is not with us today. So she'll be with us in October. So for those of you who don't know me, my name is Matt Martin. I'm here at Arizona State University. And today is the reflection session for what you all were teaching in August, which was, I think it was all inpatient care. So we'll do some reflecting on that today. I did have just two announcements before we keep going. The first one is about some focus groups that we are organizing. So we're going to put together some focus groups for faculty members, instructors like yourself, and then we're also going to do some focus groups for the residents as well. And we're hoping to use this feedback to improve the program, as well as just to better understand what we did well, what did not go well, and see if we can share our results, maybe get them published as too. So these focus groups, they're going to be an hour long, and they're going to take place sometime end of October, beginning of November. Catherine is the one who is going to be reaching out to you. I think we already have a list of a lot of people here, a lot of the participants that have already expressed a willingness to participate. So if you haven't received that email from Catherine and you're interested in participating in the focus groups, please just send her an email. We do have an incentive. We are offering a $15 DoorDash card to anyone that participates. So this is both faculty and residents. We do have some caps though. So we can only take, I think, 3 faculty from each site and 3 residents, I believe. Yeah, I think so. I'm looking at my notes. So that helps us sweeten the deal as well. So yeah, once again, if you haven't received that email, just reach out to Catherine and let her know that you're interested, and she'll get you all signed up. Any questions about the focus groups? Okay, great. Yeah, we actually did this for another project where I used a DoorDash gift card, and it was really nice having someone bring that meal to my office. So if you haven't done it before, it's pretty nice, but it's kind of hard to go back to bringing your own lunch once you start doing that. Okay, the second thing I wanted to mention was I think it's just a reminder to, after your teaching session with the residents, to complete the feedback forms that Catherine is sending out. So just a gentle reminder to complete those forms. Did anyone not receive those forms in August from Catherine? Okay, I'm seeing some.
I didn't get them.
Okay, so no from LaDonna. Okay, then others look maybe a little confused. So maybe you're not getting the forms.
I don't remember getting them.
Okay, Tony, you said you're not getting them?
I don't remember. If
Okay.
Yeah.
All right, let me follow up with Catherine just to make sure that those forms are going out. These are forms that are just trying to help us collect immediate data, immediate feedback on how the sessions are going.
You're talking about the feedback forms, right?
Yes, that's right, the feedback forms.
So there is an active link on the Canvas site for the feedback form for residents and faculty, and that's where I've been doing it. But it's not coming through on the emails.
Okay, it's in Canvas. Okay, that's helpful to know. Then I'll check with Catherine to see how she's sending them out. Maybe she's just assuming that everyone is going to Canvas.
I think she sent it, I just found it from August 4th. So it was a while back.
Okay, so you did get the email, Hader. Okay.
Yep. This is Sarah from Mercy. I'm also getting them via email. I think the issue is they're coming out very early in the month. And so if they're scheduled for, if I'm not giving the module till later in the month, yeah, I totally forget that I need to do that afterwards. So maybe being resent that towards the end of the month might result in a higher response rate.
I like that idea. Thank you, Sarah. Okay. Great. I know some of you are doing these modules, teaching your residents early. Some are doing it middle and then later. So lots of variability, which is okay. Okay, I think that was the second announcement. Any other comments or questions? Anything to discuss with
the email? It was August 4th, and we're typically the fourth Thursday of the month. So
yeah. Okay, great. Just another example then. Okay, so today, like I mentioned, we're reflecting on the modules for inpatient management of OUD and chronic pain on top of OUD. So just a reminder, we're going to do the breakout sessions. So this is going to be 15 minutes. So you'll be put into a group here on Zoom, and you can just use that time to reflect, talk about how things went. I'm going to copy and paste the questions that you can use to guide your discussion. So I'm going to put those right here in the chat. Okay, there we go. So the first question asks, what did you end up doing during the in-person session? What went well? What did not go so well? I think we could have a good discussion about that, because I recall back in August, some of you were explaining how providing MAT in the hospital is just not feasible right now. There's really nothing set up for it. So I'll be curious to see how your discussion with the residents went. The second discussion question is, how did you handle learning the content? Yeah, yep, just like I was talking about, even if you're not set up for it in the hospital. The next one, did anyone do something different than what is on the teacher's guide or use any new resources? Last time we met, I also recall that some of you were completing the modules at the same time, like in the same room as a group with the residents, which seemed very effective. So perhaps we can discuss that some more or talk about other strategies that you all came up with. And then the last one, overall, what feedback did you get from the residents about this module? Okay, so those are the questions you can use to guide your discussion as a group. Let's see, how many do we have today? We've got, looks like we have about 11 people here today. Okay. So let me get the groups going. Okay, so we're going to have 3 groups, and there's going to be about 3 to 4 of you in each group. Okay, so before we break out into different rooms, any questions? No? Okay, everyone is ready to reflect. All right, I'm going to open those rooms right now. We'll see you in 15 minutes, and I'll give you a 15-minute reminder.
Hello.
Hello, Adam.
Hey, how are you?
Good, how are you doing?
Good. Is it just us?
No, you should be in a room with Sarah and Steve. Did you get the invitation?
Don't see it.
Okay. If you're all right, I can just move you directly to that room if you're okay
I
with
think
that.
I can, hold on, I think I got it. Just one sec.
Okay.
That's perfect.
Okay. Welcome back, everybody. Sorry, I missed can people hear me? I feel like I'm talking at,
Yeah, we can hear you clearly.
okay, thank you, thank you, thank you. See how many people do we have here? Oh, great, okay. Sorry, I missed the first part of it. I was running very behind in clinic, but thank you for starting. Okay, so we're gonna report out, talk about what you guys discussed in your groups, and I'm going to take notes so that we can keep revising this curriculum and we can also learn from each other. Some of these conversations in the past have been super, super, I don't know what the word is, just like, I've learned a lot from you guys about thinking about how to teach differently and creatively and different ways of thinking about things. So I think they've been very fruitful and informative. So why don't we have group number 1? Do you know who you are? Oh, great.
Yep, that's our group. I took the notes. So for the first question, what did we do that went well and not so well? The things that went well, I think, were being able to hear how examples and apply them of actually prescribing MAT in the hospital, and how to monitor, how to initiate, and to titrate the doses. It was very clear, especially those slides that were in the teaching manual, the teacher's guide. I just printed those out for the residents because the not so well part was that I think a lot of our residents are getting fatigued by doing this number of modules, even though a lot of us are blocking time for them. A lot of people just maybe are clicking through it to get to the certificate, or just kind of not doing it and knowing that the faculty will teach the content anyways because we care about teaching the content. It was good to have those resources, definitely, to make it efficient to teach and apply it directly. And maybe just they work through it with in front of them. One thing that was difficult, in our faculties, not everyone is a physician. There's a lot of behavioral scientists teaching the modules. So for a module like this one, where it's very treatment heavy and monitoring for things like QTC, it is just difficult to treat, and also difficult to field questions from residents of when to adjust treatment. I think one thing would be good, maybe this module be led by a physician who has more familiarity, especially with treating withdrawal in the hospital. Other good things, a lot of residents picked up on patients that they'd seen, and they thought back and reflected as they were doing this activity, maybe this patient wouldn't have left AMA if we had initiated better treatments for their withdrawal, if we had understood it and done something differently. And another challenge is nothing the module can teach, but a lot of us don't know what our formularies are in our hospitals as far as what indications they'll let us prescribe methadone or buprenorphine for. Sometimes it's restricted to certain specialties like oncology for methadone in my hospital. So kind of working through that as far as administrative things is local practice, but we all kind of had a feeling that, and also with the resident feedback, methadone seems so promising to start it as a withdrawal treatment, but the challenge of methadone clinics being standalone and continuing care. A lot of us don't have social workers that have any clue where a local methadone clinic is or how to contact them and to get patients with a handoff. So many of the faculty and the residents were pretty hesitant to, recommend methadone, even though medically indicated, because socially would not necessarily have any firm continuity. So linking to like the resources question, I know we've talked in previous meetings about different websites, if there's any like professional resources specifically for methadone clinics, doesn't really seem like they're necessarily very standardized in how to link in with them. But that would be something that maybe we could also guide our social workers to when the time does come. And then another question regarding learning content. Sometimes feels like a lot of information to digest in the in-person meeting when the residents haven't done the modules, which I think a lot of us are finding it's inevitable. We're never going to get 100% of the residents to complete it, no matter how we encourage them. So a lot of us have adapted to teach the high yield module content, maybe have some paper materials or emailed materials available for them to then work through things. And then one more aspect of feedback from the residents was that as good as a lot of the modules and the taped history takings are, it almost seems like people who haven't experienced taking a like actually seeing these patients, maybe it's going sometimes over their head, like they're not actually seeing as much of the benefits, or it seems repetitive when they're not catching the subtleties of differences in different modules. But I think a lot of my residents especially are asking for like shorter modules with more faculty-led teaching followed by cases. So that's how we've been adapting it. I personally thought this was a fantastic module with super high yield content that was readily applicable to patients we see every day. So I think a lot of people were happy with the content and took away a lot of new skills with a topic they were not comfortable with beforehand.
That's really helpful. And I have a few follow-up questions / resources. Can I share my screen?
Yes, one moment. Okay, go ahead, Randy.
Share my screen. I'm scared what this is going to pull up. So if you go to SAMHSA's website, I'm not sure how many of you guys are aware of this, but you can find any treatment facility based on your zip codes. Like if you're looking for a methadone clinic, if you're looking for people who prescribe buprenorphine, let's just see. This is my area code. So you go to SAMHSA and it's like, yeah, find treatment. Let's see, search. Are people familiar with this? Is this ring a bell? What is going on?
I think we've been to the site at the beginning of the program months ago, so it's a great reminder.
Yeah. So if you're ever looking for, I think you make a great point. Not every hospital, facility, or clinic is blessed with social workers and people doing some of this coordination of care. And so how can we support this? I wonder why this is not working. O2, please enter a zip code. I don't know what's going on here. Okay, but I went to the SAMHSA website. You go to find treatment, substance use disorder locator. And then basically you can enter your zip code. I'm clearly not doing a good job at this. Find treatment. Okay, findtreatment.gov. That's it. Then you enter your little zip code. Such. Okay, so it gives you like, yeah, everything in your area. You can search over here. Look, you can see by methadone, buprenorphine, naltrexone. So it's really, really great for people who are needing or performing the social work role in helping support patients. So I just wanted to remind people that this exists. And you can teach your residents that as well. Okay, I'm gonna stop sharing my screen. So a few things I heard from you. One is that it seems like there is some resident fatigue with the actual modules and that people are really looking for the more active learning. And you know, it's fascinating. I don't want to bring too much of my own residency program into this. I want to hear from other people, but we're experiencing the opposite. Like people are wanting their own autonomous time to do learning, and they appreciate coming to the classroom and discussing it, but they really like that autonomy and feel like, you know, we're trusting them as adult learners to do things. So I'm curious if other people are feeling like their residents are fatigued from that and they really want the active learning. And sorry, how do you say your name? Hader? Hader. What are you, how have you said you've been adapting it? I'm curious as to what you're doing. Are you just, because we talked last time about not even having the residents do the modules, like doing it with them, like actually going through the module together. I'm curious if you've been doing that, if that's working. That's my first question. And yeah, and I'm curious to hear from other people, like if they're experiencing the same fatigue and how you're responding to it.
So we haven't tried doing the modules together yet. And I think we might end up doing that depending on how this next month goes.
But it sounds like the residents are at least being honest with you and telling you they're not doing it, or is it just obvious from the discussion you're having?
It's pretty obvious who's done it and who hasn't,
Okay.
because you find the people who are like naturally leading the discussions and fielding a lot of the questions from their co-residents, even when, you know, kind of disseminating the information at the beginning of the interactive part.
We've
And then
had
we've
the
been
same-
trying to just teach more at the start with the highlights of at least the base.
We've had kind of the same thing too, where our residents were not doing it unless we did it together. So like the first 2 months, we had them do it on their own, and I was actually keeping track of who was doing it. So I had a spreadsheet, and I would have 1 to 2 residents who did it each time when it was on their own. Yeah. And so, and we gave them protected time to do it. So with that being said, we moved it to just doing it as a group the same week as the case discussion. And we've had much more participation by doing it that way. I have to say we were quite disappointed to see that. But at the same time, it was just realistically what was happening. So we wanted to just make sure that they were engaged. So we've been doing it all together.
Thank you for sharing that. Any other thoughts around that from other residency programs? What your gauge of participation has been with your residents and how you've tackled it?
So I had mentioned in our group that we started out, of course, with the curriculum primarily virtual because we weren't in person. And then we moved to in-person didactics, and it appears from the residents and also the faculty and even the medical students who are involved that doing the modules, going through the modules together actually is preferred. They like being engaged with each other versus individual. We were kind of unique in a way, I think, that even when we were doing them virtual, having them go off for an hour, completed, they were required to, faculty included, had to send their certificates. And so then we would have the discussion, but it wasn't as rich as it is with us in person.
So you're saying it's the in-person has just increased your level of engagement?
Yes. Mhm.
Yeah, in our program, we've also noticed we've been giving the residents protected time to do the modules. And when it comes time to meet in person and kind of go over the cases, it's just not as fruitful. So we're really looking forward to trying to do the modules together to get kind of a better, I think, because what I think, my theory is I think their medical knowledge is lacking because they're not doing it. So maybe that interest is not quite there, or the fear of not knowing the right answer is holding them back from being as active and participating as we'd like to see.
We also discussed in our group how when you do the modules on the same day as the case discussion, like right before it. So if you can find a 2-hour block where you do the module and some teaching and then do the case discussion, then everybody has received the same information and the discussion is much more fruitful. Because we've realized that even when we do the modules the same week as the case discussion, there are certain people who are in attendance for the modules, but not the case discussion, and vice versa. So if we can do it all together, the discussion is just so much better.
Makes really good sense.
Exactly, and that we found that too. We've had, like, we have protected time today for the residents to do the module for September, but the actual time when we get together won't be for about a week and a half to 2 weeks. And so some people don't do it, or some people forget things. What I did this last month is somebody had suggested at the meeting last month that they go through some of the slides. And so I went rapid fire through the slides and spent time on what I thought were the most pertinent ones, going through the module together. It took about 15 to 20 minutes. And then we spent the next half hour with the case presentation. And then at least it was a good reminder to those that had done it, and it got at least those that hadn't done it a little bit up to speed, along with the physical handouts at the beginning of that session.
That's great. That, you know, it sounds like you used it as a grounding way to just get everybody somewhat on the same page, a nice quick review. It's probably a good review for yourself, right? And so even if people did the module, did it a long time ago, or didn't do it, at least they have something, some place to start. The other thing is most of these modules, I think, have like one-pagers or associated with it. Like, especially this next one we're going to be doing, it's very clear there's a one-pager. This one, I think we put in like, I don't know, 5 take-home slides of like algorithms and kind of like one, like just like the highlights. Sorry, what's going on? There's clapping and
Yes, it worked out perfectly for a very specific reason for us.
Yeah, I was just laughing with, not at LaDonna, because that's what we had talked about, is having the actual handouts.
Yeah. Okay. Oh, well, you were in the same group. Got it. Yeah. So I think it's always nice to have that, just like a summary of things. And I think it's great if you go through it. That's a really nice way to do things. The other thing I'll say, just to comment on some of the other things that were said, is, you know, I think especially with this module, the induction for methadone, the induction for Suboxone, that can feel a little bit overwhelming. And I know somebody said that, like, you really liked having that, you know, thing that you print out. But again, I would just keep in mind that, like, these are all protocols, and like, I have to look this stuff up sometimes, you know? So I think it's like, so people don't feel so overwhelmed, we want them to understand the concept. Like, the big picture concepts are that if somebody comes in and they have untreated OUD, we need to start them on something and either taper it off or continue it. But you know, like, remembering all the doses and how to do the COWS protocol and all that stuff, like, that's why we create protocols. And it sounds like, you know, a lot of hospitals don't already have that in place. I would encourage you guys, you know, if you're, you know, trying to do this in the hospital, trying to teach your residents how to do it, is, you know, it's okay if you don't have a protocol in place, but you do have this algorithm, and maybe you can enter it into the order set. So, and without having to memorize it. So I guess the point I'm saying is I hope, I don't want people to feel like they have to know doses and feel overwhelmed by that. But they should know this is a resource and they can use it if they need to based on what's in their healthcare system. Okay, very helpful feedback. And I also, it looks like I want to read some of these side comments too before we go to group number 2. There was something somebody said, a few residents started doing the modules when we used the words adult learners and autonomous learning. Wow. I would be more keen on doing the module with the residents if I hadn't, oh, where'd it go? If I hadn't done the module prior to these meetings. Interesting. Yeah. So if really, when you start having that conversation of like, hey, you guys are adult learners, like, you know, that's interesting that actually spurred people to do it. Kind of a kick in the butt, right? Okay. Anything else we need to talk about from these handouts? Okay. Okay, let's go to group number 2.
I think we kind of went through it. That was LaDonna, Richard, Ilana, and myself. So we all agree we should do it with the residents, have the time to do the modules, the review, and the cases. And yeah, I think to us, that's the slam dunk.
And were you guys able to do both the, like all the MAT stuff and the pain stuff too, or was it too much?
For us, it was a little bit too much. It seemed a little too content heavy for that month. Again, the way I express it to the residents, just as you said, here's the resource, here's the protocols. We don't have to memorize this. It's available when we need it.
We focus more so on the MAT as well. Typically in our groups, we get through 2 cases max. We've never gotten through 3 in an hour. So that's just kind of been our experience.
That's a really nice point to keep in mind.
So we had a technological issue. We were able to get through the pre-test, which was great. But halfway through the modules, our Wi-Fi went down. But here's the cool part. I had printed out all of the handouts and already distributed those. I was so happy I didn't know what to do. We went over the handouts in detail. Then we did a couple of the cases and it went over big because it really was an opportunity to do some engage in some adaptive learning. So we did both MAT and pain management all in 2 hours.
So wait, what made it more efficient what made it more efficient for you?
It made it work when the Wi-Fi went out and we couldn't complete the modules.
Basically, you just used the handouts. You skipped the module completely and you just did the handouts and you were able to get through, you felt like that was sufficient.
It worked. Because we did the pre-test. That was the thing. We did the pre-test. So the handouts actually, and half the modules, and then the handouts going over those in detail, then a couple of the cases pulled it all together.
Interesting. That's fascinating. The one thing I worry, I mean, I think it worked out great for you. It was active learning. It simplified things. I think the only thing I would be a little bit concerned about is, to me, one of the benefits of the modules is the videos where we talk about like how to communicate things to patients. Like, to me, like, I think a lot of residents and physicians, like, we can know the information, but having conversations with patients is an entirely different story. So I feel like those can be helpful in making people feel a little bit more comfortable and how to say it, how to do it, you know?
Well, that's what happened. We were able to get through at least a couple of the videos. We went through the handouts. Then by the time we got to the cases, we did fishbowl for the first one. I was the patient, a senior resident was the physician, and he did exceptionally well.
Oh, that's great, LaDonna.
He was armed with information, armed with the video for the discussion, and both the faculty, residents, and medical students said they enjoyed it. They learned something.
Way to adapt, man.
yeah, we had to.
But it begs the question then, was that module necessary? Was it necessary for you to prepare you? What, could we have just gone with the handouts and the cases?
The pre-test, the handout, and the cases.
You like those pre-tests.
I do. I love them because it stimulates their thinking, gets them primed, as Matt said, gets them primed and ready to go. And so they are able to take in the information, and with the cases actually use it. So it was a fluke that turned out to be good. I mean, it was great. Yeah.
Cool. Thank you.
Surprising.
No, you're really finding what works for you. I love it. I mean, I feel like every time you come to some new understanding of what gets your residents most active and involved. So great. What, do we have a group number 3?
We do. Hey, Randy, it's Steve Hogue from Syracuse, New York. I guess I'll keep it brief. We sort of agreed with what everybody else was saying. I thought Sarah mentioned something that they were doing in St. Louis. She had her clinical pharmacist actually come and sort of added into that aspect of the medications, which she thought worked really well. And then one thing she thought, if she'd thought about it sooner, would have been to have the social worker actually be there as well, because of the challenges of what we talked about earlier, which is how do you get somebody into the methadone clinic? My hospital doesn't really do methadone in the hospital, unless they were on it previously, but we don't do it as an induction or as like for somebody that's going through withdrawal. Not that we wouldn't. And then Lonnie, I don't know if you wanted to speak about the methadone and some of the challenges in what you were thinking about with, just having more of a either resources, references behind the methadone and for places that really can't use methadone because we don't have methadone providers near us, that maybe that was a little simplistic, kind of who to choose methadone versus Suboxone. So Lonnie, I don't know if you want to dive into more details on that comment. Unless she jumped off.
So I really do, I like your comment though about integrating, because a lot of this stuff we're teaching is about like what is recommended and what the evidence is, but we also have to live in with, healthcare systems and what our capabilities are. So I think it's really nice to make, the residents are going to leave and graduate, and who knows where they're going to end up. They're going to have lots of probably varying degrees of resources available to them. So, some might have social workers doing this connection, some might not. But I think it's always nice that for practical purposes, while they're residents, of what resources exist now and how do I help these patients now? So whenever you can bring in people like you said, a social worker or somebody who works in the hospital who can let the residents know what resources exist, a pharmacist, that is really a nice way to do things. I don't know if anybody else tried something like that when it comes to like, how do we apply this to our healthcare system?
I'm actually a clinical pharmacist, so I'm usually there for the presentation. So I usually kind of plug in some pharmacy tidbits while we're there too. And we also have our social worker present for all of it as well. So we try to kind of make it a group effort.
That's awesome. That is really great that you do that. Okay. I know we're short on time. Did we have one more group to go?
No, that was the last group number 3.
Okay. Awesome. Thank you guys so much for sharing this stuff. It's always interesting to hear how you guys adapt to things. Yeah, and I'm just trying to think if there's any specific things we need to change about the module itself. It sounds like there is some redundancy. We made it redundant intentionally because just to let you guys know, when we roll this out nationally, like people are going to be able to pick and choose, like they may not decide to do all the modules and in any particular order. So we want to keep it enough so that somebody can just do one module and get enough from that. Understanding that there may be some level of replication, but that's just intended to cement prior knowledge. But if you are really strong that like this thing is too much like this other module, definitely let us know, because we want each one to be distinct and kind of building off each other, but also that people can take it without having taken any of the other modules, if that makes sense. So, okay. Let us call it quits for now. We'll give people a 5-minute break before we start our next round of things. Thank you everybody so much for participating. And please, one more reminder that if you have not sent Catherine the names of faculty and residents who can participate in the focus groups, we really need you to do that soon. I know a lot of people on this call are not the ones who are in charge of that. So we're going to reach out to the people at your residency program who are in charge of that, but we're really asking people to sign up for focus groups. So just another plug for that. Okay, we'll talk to you guys in 5 minutes. Let's see. Welcome back, everybody. Let's see, we've got 18 people here. Okay, so we are using this session to prepare for September's module, which is OUD and pregnancy. Lots of OUD inpatient, and OUD and pregnancy. Can I get, I'm trying to look at all of our participants. I just need a show of hands if there's anybody new to teaching these modules. You. Gallery, haha. Okay, let's see. Sorry, raise your hands again because I didn't see it. I see 3 people. Okay, cool. So for these 3 people, we're going to kind of give you an overview of how this works. We'll take about 5 minutes, and then everybody else can kind of tune out, do your thing, and we'll bring you back after we're done giving this tutorial to these new people. Matt, can you help with some of the sharing your screen and going through Canvas and the website? That would be great. Okay, so for new folks, welcome. We're glad you're joining us. I'm just going to kind of give you an overview of how this works. So your residents are used to doing this modules. You may not be, but essentially what we're doing this hour is we're going to prepare you for the module that you're going to be giving in September. And what we're having the residents do is usually it's set up so that the residents take the module on their own time. It usually takes them about an hour to an hour and a half, and that's done on Canvas. And then we have you guys come in as the faculty and lead an hour-ish in-person or live session with the residents from the faculty guide. And we're going to go through what that looks like for this next month. So your residents know how to use Canvas and watch the modules on their own time. We have been discussing in some of these faculty development meetings that sometimes the residents are not doing that online module, and you might need to do it with them. So it depends on, we can talk about what you guys want to do, how you want to plan for that. But the idea is that they take the module in their own time and they spend an hour with you and apply it in a active way. So the things that you guys need to know is we'll plan for the session, and then you will come back in a month after the September session, and you will recap with us how it went. And that allows us to collect feedback and to understand how to improve it, to think about different ways of teaching it. So the things that you need to be aware of is, one, we have a website. The website is a place where it tells you how to log on to this meeting, that we send you emails to remind you that. And it also has all the modules and all the teachers' guides, and it has places you can share resources with each other and all of our contact information. The other thing you should be aware about is the Canvas site, which actually has the modules. And so Matt is going to briefly show you how to access those 2 components.
Hello, everyone. I just put the links for the website, and now I'm going to add the one for, there we go, for Canvas. So you can access the website. It is a Google site, so if your employer does not like Google, you may have a firewall block on it. So you might have to access it a different way, perhaps on your phone. And then Canvas, you should be able to access as well. So I will share my screen. All right, here we go. So here's a website. Lots of good information here. We've got several videos that just give you an overview of the program, as well as a navigation of the website. So you're welcome to watch those videos. We also have here in this second tab, links to all of the teacher guides. So for you all, this would be, is it right? Yeah, OUD and pregnancy. So you just click on that link and it will take you to a Google Drive folder. Here, I'll show you. My phone just woke up because of what I just said. So yeah, so this is the document for your teacher guide. You're welcome to download it, print it off, and use it for your instruction time with the residents. Okay, going back to the website, we have other information here about the modules. If you go to this third tab, you can register yourself to access the modules. And then this second link is the permanent link that you can use after you're registered to access the modules at any time. So let me go to the Canvas shell. Canvas is the name of the platform, the system that we use. It's kind of like Blackboard, if you remember that from your college days. So this is the student view here on Canvas. This is what your residents will see, I think, as well as what you will see as well. And so here's the welcome page. They can click on the modules, and then they can see all the different modules that we've created for this curriculum. So I'm going to scroll down to OUD and pregnancy, which is right here. Okay. So clicking on here, there's also instructor materials that you can access. So that's the same teacher guide. I'm going to skip that. And here we go to the learning objectives for this module. So this is what the residents will see. They can take the pre-training quiz right here. And then that should bring them to the actual module itself right here. So you're welcome to watch this. It would be a great idea if you were. It's interactive. There's audio. You can hear Randy's wonderful voice narrating. And so it would be a good thing to spend some time familiarizing yourself with the module and the content. Okay, so that's the Canvas page. So let me go back to the website. There's just some more information if you're interested about our monthly meetings and about all the topics that we're covering. We also have some, here's the Zoom link, and then you can see the calendar. This tab is about the pilot sites that are participating in this program. So we have programs from all across the country. This is also where, if you're very curious, here you can see a map of the programs. But if you're very curious, you can also watch our recorded videos from previous faculty development sessions. Okay, and then here, this last thing, actually second to last, just a tab for resources. We're still building this out, trying to add more resources. And then the final tab has contact information. So if you ever need to get a hold of me or Randy, we have our email addresses, as well as Catherine, who is our student helper. She's very responsive, great to work with. And so that's the website, and that's Canvas.
Awesome. So the only thing I'll just reiterate is that just to explain one more time that with each module, there is a pre-questionnaire, there's a post-questionnaire, like questions that all the residents do, and there's the actual interactive. That interactive is the actual module. So yeah, you guys should definitely make sure you go through it before you teach it. And the other thing I'll say is that the guides we put together, the teacher's guides, are there for you to use. You really have to do no preparation in order to teach it. However, you feel free to tweak it however you want. People are doing some very creative things, which is why we're having these discussions to learn and hear how people are doing things. But I don't want you to feel like you have to follow it, you know, word by word. Okay, so for the new folks, what questions do you guys have?
It was good, thanks. I don't have any. Yeah.
Okay.
Good.
Let's go ahead and get started then. So for this next 45 minutes, I'm just going to, we're going to have you guys break out in some groups. Really quickly, for those of you who weren't here, I just wanted to remind everybody that we've invited everybody to participate in a focus group that we're going to be having in the end of October, early November, for 3 faculty members from each program and 3 residents for each program. We're really, really hoping these are going to be really informative for us about the value of the curriculum, and it's going to help us continue to grow it. It's going to help us publish on it and spread it you know, across the country. So it's really important that people participate and share their perspective. So if you have not signed up and you are one of your points of contact for your program, please make sure you sign up for the focus groups and email Catherine. Again, we need 3 residents and 3 faculty. And just a reminder, everybody who participates will be getting a $15 DoorDash card to have a meal of their choice with during their focus group. Okay, so for this module, OUD and pregnancy, before we actually get into what you guys are going to teach, I just wanted to give you kind of a few important issues that are going to probably come up. So the module touches on the evidence base for treating opiate use disorder in pregnancy and in L&D and the postpartum periods. However, many healthcare systems, including my own, are really not set up to manage some of this stuff, such as what we call now is neonatal opiate withdrawal syndrome. The more general term is as NAS, neonatal abstinence syndrome. So many healthcare systems are not set up to manage that. Many healthcare systems do not use, for example, the Eat Sleep Consult protocol that's introduced in this module. Many healthcare systems still continue to recommend Subutex over Suboxone during a pregnancy, even though we know that that is actually, the evidence is changing around that and is moving more towards Suboxone. So there's a lot of current evidence that's not being employed in practice for many reasons, whether it's cultural, health systems related, lack of expertise available, lack of resources, etc. So one of the challenges of this module is going to be acknowledging all that while also teaching the evidence. So and I said this in the last session, but your residents are probably going to graduate and will end up at different healthcare systems, right? They're going to have different protocols in place, different capabilities. Some may be able to do all this stuff, some may not be able to do, but our goal is to empower, to acknowledge they might not be able to apply all that right now, but we want them to have the latest evidence so that they feel that they can use it and adapt to the appropriate setting. So again, healthcare systems evolving, resources evolving, but we want people to feel empowered with what the latest evidence is. So the other thing I want to acknowledge is that a lot of people probably teaching this module might not have expertise in taking care of pregnant patients. I'm not sure who's going to be teaching this at your healthcare system or your residency, but it might be worthwhile for you to partner with faculty in your program who do maternity care and who are aware of your health system's protocols around MAT during pregnancy, what happens to the infants, when they're experiencing NOWs, and how the healthcare system manages all this stuff, like different things that come up, especially like pain during labor. So if you are aware of your, the other big part is a lot of this stuff is related to medical legal stuff around patients who are, using Suboxone or methadone during their pregnancy, and every state has different mandatory reporting requirements, based on, your Department of Children's Services. So it might be helpful to know what those are, and so you can share with your residents. So you might actually have to do a little bit of investigating to understand how your healthcare system works, to be able to inform your residents about like how to apply this information. So for example, let me just give you an example from my healthcare system. I know that if somebody is on Suboxone, during their pregnancy, our Department of Children Health Services, it's mandatory reporting to them. But if the DCF learns, for example, that the person is on maintenance therapy for addiction, they're doing well in recovery, there's no concerns from the clinicians, then they won't open a case. So it's nice to know these things because it allows us to counsel our patients around this. Some patients are hesitant to be on MAT if they're worried that they're going to be reported to DCF, and therefore they don't make a decision that's probably in their best interest. So I'm saying all this just as a caveat, for it might be helpful to partner with people who understand the healthcare system, understand the medical legal system, so that if your residents ask, you can provide information that's pertinent to your system. Okay, so that's a lot of talking. Let's get into the actual what's going to happen in your in-person session. So if you've pulled up the teacher's guide and you've looked at it, there's 4 different cases. There's cases around counseling around MAT during prenatal counseling, counseling around NOWS or NAS, managing pain during labor and postpartum care. So there's 4 cases. There's also a very succinct summary handout that is, I think it's really nice. You can use it, refer to it, you can share it with your residents ahead of time. It will help guide all the case discussions. That being said, there's many different ways you could do these 4 cases. Somebody in our last session made a nice point that it's really, really hard to take a deep dive into more than like 2 cases an hour. So there's a few things you could do. You could either do a fishbowl where all the residents sit around and you have one person as the patient and the residents practice playing the doctor. And maybe you do 2 of those. You pick the 2 highest yield cases and you do 2 of those. Maybe you do one fishbowl and then have people break into small groups and they can pick one other case. Maybe you have them just do all small groups of the 4 cases. Or one thing that another recommendation would be to have people pair up in small groups and each pair take a different case. So this pair takes case 1, this pair takes case 2, etc. And then when you come back into a large group to talk about the cases, each one can share what they talked about. So there's a lot of different ways of how to do the 4 cases. And you might decide you don't want to do all 4. You just want to do 1 or 2 and take a deep dive. So we are going to have you guys talk about how you're going to do this in your breakout sessions, and then we're going to reconvene. We'll give you 15 minutes. So Matt, if you could put these questions in the chat, but the questions that we want you guys to address are, first of all, the module itself. For those who have gone through the module, do you have any feedback about the content? Or questions about the content, because we're here to address questions as well and share pearls. And then as far as the teacher's guide in your in-person live session, we want you to talk about how you're thinking about doing it. What do you think of the activity? Any adaptations you want to make? How do you think you're going to handle the 4 cases? And then another thought question to think about is, are you aware of your health system's protocols and approaches to pregnant patients with OUD and how NAS is managed? And do you plan to teach this session in partnership with another faculty who has a better understanding of these issues? And how else might you prepare to help understand your system's culture better and share the information with the residents? So we're going to put you in groups. We'll do 15 minutes. So we'll reconvene around 4:40 Eastern Standard Time. And we'll see you guys soon.
Okay, everyone, you should see an invitation to join the breakout room. If you're on your phone, it might be a little hard to see. Okay, looks like we have 4 rooms with about 4 to 5 people in each one.
Great.
Perfect.
We still have Melissa Arthur's here. She hasn't gone into a room.
Hi, Melissa. You should see the invitation to join the break room for room 1. She might be away from her desk.
Okay. Okay. Welcome back, everybody. We're going to go around and share what you guys discussed. So who is group number 1?
We were, I can go over that. Okay, so some questions that may come up would be about mandatory reporting. And we discussed how that might be different, possibly from state to state a little bit. But that's something that plan to look into. Pretty much everyone plans to look into their hospital's protocols for managing these different things. A couple of the groups will be able to include OB faculty. And I think that's a wonderful idea. That was actually something that came up in our discussion last hour, was having specialty faculty members join. That can be really helpful. I know myself, I'm a health psychologist, and a lot of the material, I wouldn't be able to field some of the residents' questions, I'm sure. Let's see here. In our program, we've been doing 2 hours together. We did manage the time to do that, and the residents seem to really like it, where we watch the protocol together, or excuse me, the module together, go through the pre and post questions. One thing that might be changed if we end up running out of time would be, or if any of the groups end up running out of time, would be to focus on the initial prenatal case and the post case, because those seem most pertinent in these practices.
You mean case number 1? Is that what you're talking about?
Yes, that's correct. Yep. Yeah, just if we run out of time and it has to be cut down a little bit, that's what we'd be focused on. That seemed most relevant. And let's see. Some questions might come up. One of the people in our group mentioned that in their system, they do UDSs on all pregnant patients. So that was an area that the mandatory reporting might come up, and yeah, it should be an interesting didactic. I think that was.
And yeah, you are required to get a patient's permission in order to do that. Yeah. Okay. Thank you for sharing that. Anybody else from group 1 want to add anything to that? I don't think any questions came up, right? It was more just like you're anticipating that you're probably going to need to involve some other people and do some investigating before the actual session. So that's good to acknowledge that. Okay, thank you. Group 2?
I was in group 2. I can share some of the stuff we talked about. We also discussed the UDS screening at the beginning of pregnancy, because some of us all have a policy that that's the case. And yes, you need to get the patient's consent, but oftentimes that's encouraged. Bridget, I think, had a good idea about, or not, like just her hospital's or her program's policy is that they, discussed in the first trimester, and they talk about rescreening at 3rd trimester. And if that's the case, they kind of talk up front about, we need to discontinue use of various things in pregnancy, and just letting the patient know sort of like, if you do have a positive drug screen, we will check baby's urine. That's something that's going to be recommended at the hospital, and et cetera, et cetera. So just being upfront about what the neonatal protocol is from the get-go. And then we also talked about getting like a hospital social worker as like a collaborative teacher for something like this, to kind of go over again, like your hospital's policies and protocols for women with substance abuse disorder, especially opiates, and like what would mandate a DCF referral, and kind of how they work through that when they do get a referral for substance use.
Great. I'm hoping as you guys are thinking about this, who to contact in order who to contact, right? Like finding the right people, which will probably be really helpful in this discussion. Okay. So again, it sounds like more planning on who to involve. Okay. Group number 3. That was Claire, Garav, Richard.
I wasn't sure what group we were. So yeah, I can share. Our group focused pretty much the same as the first two groups. We talked a lot more about just like anticipating questions that might come up, how to incorporate the conversation around mandated reporting, knowing policies. And so everyone's gonna be prepared for that aspect of the conversation. And then, with respect to what our plan is for actually teaching it, we were looking, our group kind of felt like 4 cases was a lot, but that we would figure out among the people who are going to be facilitating the discussion, what the most important ones for our residents will be and how we're going to go about doing that. I think Richard brought up maybe even simultaneously doing different cases and then doing a report out. So that was a nice idea I hadn't thought about before. Our group tends to do the fishbowl style. So yeah, anything I missed, guys?
I think that's pretty straightforward. Yeah, I want to look into the mandatory mandated reporting laws here locally and how that happens more specifically, because I'm sure that will come up as a question.
Yeah, and I'm glad that you guys there's so many different ways we could do this, and I'm really curious as to what works for you guys. So I mean, the fishbowl, one big group actively all engaged is like one end of the spectrum, and then the other way you described is like the complete opposite end, like having people do pairs but each do separate cases and then come back to the large group and report out what they talked about. So yeah, I think the first way is much more active, you're engaging everybody, but the second way is also really cool. If people they have to produce something, right? They have to share with the rest of the group what they talked about. So it does require them to be actively involved. Yeah, so we'll see what you guys decide to do and what works when we talk about next month. Okay, room 4, Eliza, LaDonna, Lindsay, and Rihanna.
All right, so uh-oh, our Wi-Fi is going in and out again today. So in our group, Eliza had mentioned that they're primarily, she's a PGY3 FM resident, yay! And they're virtual in terms of their didactics. So what she has done, which I think is really awesome, she's prepared some slides after reviewing the module. She's prepared some slides for takeaway points that she's going to present, which I think is fantastic. And then in terms of going over the cases, I know virtually it's a little difficult to go over the cases in terms of separating out residents, but the beauty about Zoom is that you can break into groups. Then the ugliness about Zoom is it is Wi-Fi dependent. So, and there's just not that interaction, but I'm excited that Eliza is excited about this particular module. They do have significant prenatal patient care in their residency program, as does ours. So this is perfect in terms of engaging residents in this particular module. She believes that she can really get them engaged because her cohorts are actually engaged in prenatal care. Also, with respect to my program, we have an opportunity to have a half day or 2 hours. Actually, we have 2 hours, but the others have a half day. Having a half day to actually break into teams, do the module, break into teams in small groups and with different cases and have them go over the cases. And then of course, a report out as well. I was thinking too, to actually have the residents break out into teams. And then we have a fishbowl case where they can use some of what they've learned from the cases. With respect to the actual module itself, there were a couple things we discussed. We like the 4 Ps. We think presenting the 4 Ps up front early is going to be very good in terms of residents grasping how to collect the social history. Our residents see substance use disorder patients. They do get training on how to take a substance use history, but I think the 4 Ps will actually really enrich their current knowledge. The videos were very good. We did talk about, though, the physician in the videos with respect to the patient care, he was looking past the patient reading. So my residents will and faculty will pick up on that right away. And they will be so focused on the physician not looking at the patient, they won't hear what's going on. Because we are very committed to them engaging the patient face to face.
These are actors. These are residents from my program who are playing the doctor role.
Well, it was
it's me holding signs that says, read this, read this.
So that was, but that's one of the things that will come up. Dr. Porter, he was reading. So I just want to let you know there's probably going to be some feedback there. There was one section of the video that jumped from depression screening. I know we use the Edinburgh in our prenatal clinic. We also use the PHQ-9, and it went from depression to what other infections should you screen for. So there was no transition in the module from depression to what other infections would you screen for. And I went back and then went forward, maybe thinking I missed something, but that's going to be something that the resident will ask about.
That's helpful. Thank you. I'll have to look at that.
Yeah. And then the one last thing was in the MD case, you know, when she's coming in for prenatal care, she hadn't used opiates in 2 months prior to, you know, her visit. So in planning, because of her history of opiate use disorder, having been on Suboxone, took herself off of it. The question is essentially was, you know, how would you, you know, move forward with her? So the question was, how do you decide which drug to put her on if she hasn't used? And so that question is going to come up. Do you start her on Suboxone? Do you start her on methadone? Do you titrate her up? Where do you go with that?
Yeah. So thank you for asking that question. I feel like we don't have a lot of content questions being asked. So I'll tell you my thoughts on this. And then again, I defer to larger faculty to also chime in because I don't have the answers to everything. But it's same philosophy, regardless if somebody is not currently using full agonist opioids, meaning whatever the patient prefers is usually what you're going to want to start them on. Most patients, at least in my experience, know the difference between Suboxone, know the difference between methadone. I'm not teaching them what the difference is. They usually know what they want to be on. Now you can make recommendations, you know, if somebody, you know, based on all the things we've already talked about, you know, somebody really needs that daily structure and that accountability, and a methadone clinic feels like that's a higher level of care choice that's really going to support them, you can make that recommendation. If they want Suboxone and you think hopefully they'll do well in that, you know, that's great too. So I usually ask the patient, what have they tried in the past? What's worked for them? What hasn't worked for them? And what do they want to do? If you're going to start Suboxone and they're opiate naive, meaning they don't have any opiates in their system, you're not worried about precipitated withdrawal. So you can just start them directly. If they're opiate naive, you might start at a lower dose just so they don't get like a little buzz from it. Like, so as opposed to, you know, all of a sudden starting 2 tabs or 16 milligrams of buprenorphine a day, you know, maybe you'll start with like, I don't know, 8 a day and try that and see how it does, and then take them up to 16 milligrams. There's no exact science to this, but the biggest thing is you're not worried about precipitated withdrawal, so you can just start it. Same thing with methadone. I mean, they would have to send them to a clinic. You obviously can't do it, but if that's what they want, I would plug them in immediately to a methadone program, and they will start them and titrate them up to the appropriate dose.
So exactly what you just said is what we were talking about with respect to that being in the module.
Oh, it's not in the module.
No.
And what you're saying is it would be helpful if that were in the module.
Yes, yes.
Okay, remind me again, is that case embedded in the module or was that, it is? So we need to add that answer to the, in the module.
Yes. Mhm.
Okay. Thank you for asking a content question. Okay, is that it, LaDonna, or did you have more?
That's it.
Okay, does anybody have
a clarifying question about that? So if somebody hasn't used in 2 months, then you would want to start them on an opiate? I mean, then you would want to start them or after a conversation with them?
So obviously everything is a conversation, right? We can start people on stuff. If somebody came to me and they had opiate use disorder, they're pregnant and they're not on anything, I think it's a shared discussion about, you know, how are you doing in your recovery? What's going on in your life? Understanding how stable they are. You know, the recommendation is that, you know, pregnancy is a highly stressful time, high risk for relapse. Most people do really well on medication for opiate use disorder. So it's highly recommended. And, you know, you can have that discussion. And if they understand and they say that makes sense, you know, based on their lifestyle, and they want to be on it, of course. We can't make people do anything. And maybe they have 20 years of recovery, who knows, and they don't feel like they don't need it. And that's a discussion to have too, and that's their decision. So again, it's going to come down to the individual circumstance and the shared discussion you have with people. And if anybody else wants to chime in here too, feel free. Share any other thoughts. I like these content discussions. So thank you everybody for your feedback. It sounds like there's a few things we can do in the module itself, which I will send those edits to our instructional designer. Any other last minute comments or questions?
Last minute comment. One of the things that we like that Eliza mentioned, which was absolutely awesome, is we like the prenatal. The way it was sectioned was awesome. Prenatal, delivery, postnatal. That was really important because for learners, it helps to focus them in terms of what to do in those particular times of pregnancy. Stages of pregnancy, from prenatal all the way through postnatal, and then the following postnatal period after that.
Awesome, thank you.
You're welcome.
I have one quick comment. I think, again, the module was really helpful. I was telling people that unfortunately in our practice, we aren't, prescribing Suboxone, and we do have resources for some methadone clinics. But I think if that could be included as a part of the module as well, to get to know your resources. I know they talked about like a comprehensive team and plan, but part of your management and treatment includes getting your resources available, like the clinics in the area, social workers in the area, your L&D team, to see what the protocols are. I know our NICU team, our newborn team already has protocols for NAS and things like that. So if that was a part of the module, I learned so much here during this conversation, but I think the residents could benefit from that too, that's part of their management thinking for their patients.
So very good point. So what are your recommendations based on that for the purposes of this module?
So like maybe like interdisciplinary teams to think about, like as a part of your management. One of them is find your local resources, find out your local social worker, find out your team at the hospital who deals with this, like where to go to I feel like my residents will just be like, oh, like, where did you get all these answers? How did you know to go to this person to talk to that? And I'm like, I kind of want them to be a part of their community as well, to say, well, these are the clinics in our community, and this is where you can find those resources. And this is our social worker who will help with this specific scenario. And on-site in labor and delivery, this is the care manager who deals with this. So just maybe like a slide of like things to think about in the interdisciplinary team, like find your social worker, find your local DCFS laws, find these things out, to kind of like food for thought.
Cool. Thank you.
Thank you.
Okay. Well, I don't want to keep people past time. Thank you everybody for sharing. A reminder that you're going to come next month. It is October the 5th from the 3 to 4 Eastern Standard Time hour to report back how things went. And Catherine is going to be sending you guys feedback forms. Please complete those and get those back to her after your session. Have a good rest of your week.